For our very first Workers Experience podcast, our guest is Bheki Mamba. Bheki Mamba is the current president of the Swaziland Democratic Nurses Union, and he also serves as the second deputy president of the Trade Union Congress of Swaziland. He's going to give us deep insights into why the healthcare system generally seems unable to properly serve humanity by containing the COVID-19 pandemic. He's also going to take us through his rich journey as a worker and as a trade union leader, both locally and internationally. We are grateful you could all join us in this journey. Welcome, President Bheki Mamba of the Swaziland Democratic Nurses Union and the Deputy President of Tukoso. Welcome to our first podcast, Chief.
Thank you very much, my leader. I'm very happy to be here.
President, I think our first question, maybe to kick off the conversation, would be it's a very difficult period for all of us globally, for us as human beings, but particularly for health workers. How have you found the period as a trade unionist in the health sector?
Well, this is a very challenging period, my leader, I would say. Particularly because we are seeing a lot of number of issues that are not, in a way, not favoring, in particular, the healthcare system. Not only in Swaziland, but I think globally, we are witnessing that. We are witnessing healthcare systems that are, I would say, that are crumbling and that are not in that sense then servicing well the interest of then the people who need care.
Yeah, I mean, to you, what would be the main reason for this challenge that the healthcare is facing? Would it be the entrance of private capital into the healthcare system to the extent that governments have sort of pushed back from spending in healthcare for citizens?
Yes, there are a number of issues that I think we have got to consider. I think some of what you are mentioning is correct, but again, we have got to look also into the historical background in terms of where are we coming from. You would appreciate then that around the 1980s, there was what is called then the structural adjustment programs that was introduced in most of the developing countries, including Africa. And that had a very negative effect into our healthcare systems, whereby the majority then of our government had to take up loans, and in that regard, there was then this attitude of then government wanting to reduce spending, in particular to health, and that resulted into a situation where now you are then seeing healthcare systems with limited funding. You are then seeing healthcare systems with limited human resource. You are seeing healthcare systems not developing infrastructure. You are seeing healthcare systems running out of medicines and medical supplies. Now, that is then the serious challenge that is facing our healthcare system, both in Swaziland and globally. But again, I would say it is worse when it comes to developing countries.
Okay. Countries like Swaziland in Africa, but we see the international, the developed countries also struggling in this regard. I know that you've had a lot of exposure internationally. Is it also the same problem that they're experiencing, where They talk about limited number of beds, they talk about limited number of personnel, and people are literally dying in the corridors of hospitals and so on and so forth.
We must appreciate, Comrade, we must appreciate the role of capital as well in the delivery of healthcare services. We must appreciate that in hospitals you will find there are drugs, in hospitals you will find machines, in hospitals you will find a number of these automated systems. And these automated systems are mainly coming from capital. And that is what has made then the healthcare system machinery to be very expensive. To an extent that when you go global, you will appreciate that the pharmaceutical industries are the richest people in the world. They are leading in the world in terms of income generated from the health sector. Now, then you must appreciate again that the healthcare system has become an industry that is sort of now becoming a commodity that is being sold in the market and therefore generating a lot of resources for the pharmaceutical industry. And that is very critical for all of us to appreciate. That is why then we would appreciate that there is also this thing that is called patency rights, which is becoming a global debate now, to say there are countries who are given these patency rights to an extent that then they will charge fees, exorbitant fees, and no one will challenge those pricing of the pharmaceuticals. So that is what then is the challenge that is making the healthcare system unaccessible, the healthcare system unaffordable, the healthcare system failing to deliver services that is needed by the populace.
That's very interesting, President. Speaking about the patents and the pharmaceutical companies, do we, in your knowledge, do you have companies because I know there are 3 or 4 big companies that produce medicine around the world. Maybe some in Europe, especially in Germany, and others in the US. Do we have others who are or patent rights for African producers of medicine that could perhaps limit or reduce or manage the price for drugs, or any arrangement that has been made or attempted towards reducing the price of drugs in the period of 10-20 years from today?
Yes, you are correct. The majority of these big companies in the pharmaceutical industry, they are found in the Western countries, and none is found in the developing countries. And, that is why you'll appreciate that countries like South Africa are beginning to engage in that debate. Now, to say, how do we as Africa create skill? How do we create research? Because then we must appreciate that we are not doing well in Africa in terms of research. And therefore, the 90% of the information or the data that comes from research that we are consuming is data that is coming from Europe. And therefore, it will be then difficult for Africa to generate skill to an extent that then you can able to produce drugs, produce automated machines that can assist in the healthcare system. Because we need that skill and also need that data. So hence, that is why we are consuming what is produced in Europe and we're not consuming what is produced in Africa. That is the skill that we've got to develop.
It's a very interesting debate, President, given the issue of the Madagascar cure to COVID-19 that has split opinions of Africans. Some saying no, we must reject it, and some are saying let us try it as long as it doesn't kill. What doesn't kill can only make us strong. But I want us to move to the local conditions, President, the health conditions. I think, if I'm not mistaken, you joined the health sector in the 90s as a nurse, or as a health practitioner, as we are now being meant to be politically correct in addressing these positions. What are the sort of changes that you've seen in the health system from the time you joined up to now, that some of these things are being exposed by COVID in a way that we never understood them? Maybe now COVID has given us a very good view of what is really happening.
Yes, you're correct. I joined the health sector in the late 1990s. I started working at the Good Shepherd Mission Hospital in around 1998. And by then, you'd appreciate that was the time when the malaria condition was at its peak, and it was actually killing a lot of our people. And we were there managing that condition.
Oh, yeah.
And when we were coming out of that condition, we were then again faced by the HIV/AIDS pandemic. Also, that ravaged the healthcare system and, killing most of our people.
Yeah.
Now, these are conditions that were seriously challenging to our healthcare facilities, to our health workforce, in the sense that a majority of our workforce had to leave the country for greener pastures in Europe, greener pastures particularly in the UK, Australia and Canada. Now, what we must appreciate is that very little we have done as a country in respect to infrastructural development. And most of then our facilities, the majority of our hospitals, we appreciate they were built by the missionaries around the colonial era. And therefore, they have a lot of limitations when it comes to the infectious conditions that are coming up today. And of course, I must say, those days, things were not as bad as they are. They are today. I think our healthcare system have been going down, have been showing signs of decline to an extent that today we really are seeing a crumbling healthcare system.
It's interesting that you mentioned the issue of infrastructure. I remember a few years ago, maybe 10 or so years ago, one of our grievances was the provision or the building of pharmacies. Is it pharmacy storage areas in the healthcare sectors, in the healthcare centers, which ended up being built? I know that, for instance, because I'm familiar with Mangayane, they ended up building. But, we have seen some of the progress, if I may call it that, in terms of the infrastructure. What is the key issue in the infrastructure? Is it the limit, maybe the limited number of beds for patients, or the issue of how the patients and the healthcare workers interact in terms of, do we have good stations for nurses where they can monitor patients, or where they can rest after in the middle of the shift and things like that? What is the challenge with the infrastructure? Is it a question of its limit on the number of people who need to access the healthcare system?
Yes, what we must appreciate with our infrastructure is that first of all, those days we were not seeing a lot of these conditions that we are having today. And therefore you'll find that our wards were not as big as what they should be today. Admissions were not as what we are seeing happening today. And therefore most of then our health, our hospitals, they've got very limited wards. And you'll appreciate that today we have to separate patients. We have to separate children from adults. So we do need a lot of infrastructural development that should address that.
Okay.
And again, when you look into our facilities, they don't allow the issues of then ventilation. Because remember that today we are faced with issues of TB, and they require that where patients are placed, there must be enough ventilation.
Yeah.
And our infrastructure doesn't allow issues of, healthcare workers not contracting infections from hospitals. Because even the infrastructure itself needs to be made in such a way that the healthcare worker can also not be exposed to infections.
Yeah.
So I think that is what is very critical in terms of our infrastructure, and also this infrastructure must allow a situation where the modern equipment can also fit in and be able to be utilized in the manner in which it is required to be used.
That's a very interesting point, President, because I remember I attended a meeting. I don't know whether you were in that meeting sometime last year or the year before with some senior people in the Ministry of Health. Is it your sense, as yourself, the President, or as Swadno, that are we lacking in terms of qualified and properly experienced leaders of the ministry itself? Because I got a sense that we do have ample of people who are qualified, who have enough experience, but maybe the challenge could be how are they deployed and what responsibilities they are given on a daily basis in order to utilize those skills that they've gained, and they've gained both in class and in terms of experience. What is your sense of the leadership qualities in the health sector?
Our view will say the leadership in the Ministry of Health is, in my view, it is skewed. Now, when I say it is skewed, I mean to say it only allows a certain cadre to then be in leadership. And that then, undermines the whole Ministry of Health of then the capabilities of the different cadres that are found within the Ministry of Health. Now, I think that is what, in my view, have got to be addressed, because what it means is that in the Ministry of Health you will find a nurse, you will find a doctor, you will find a radiographer, you'll find an environmental health inspector, you'll find a dentist, you'll find a number of disciplines. But then those disciplines don't find space, no matter how good in terms of leadership qualities. They don't find space to exercise then their leadership skills. Now, the Minister of Health only allows that you have got to be a doctor for you to lead the ministry. Now, that is what then becomes a challenge of the Ministry of Health many a times.
Is it doctor as in general practitioner or doctor generally? If you are a dentist, you also qualify. If you are a gynecologist and things like that, do they look at whether you understand the health system of a human being generally, or they just take that if you're a doctor, you've got that qualification of doctor, then they think you have got the requisite skills?
Yes, the Health Act specifies that you've got to be a general practitioner for you to be appointed, or for you to be the Director of Medical Services, for you to be the Permanent Secretary of the Ministry of Health. So that is what we find as a limitation, because a number of countries have moved from that.
Yeah.
You'll appreciate that in some countries there's what is called boards, and those boards they've got your chief executive officers, and that is open to the overall cadres that are found within the Ministry of Health. That is now being what is practiced in South Africa, is what is practiced now in Tanzania, in all other countries in Africa are now adopting that move. Now, to say we have a variety of skill in terms of leadership, in terms of the different cadres that we have, and therefore we have got to utilize that skill
evenly.
Yes.
Okay. And then in terms of leadership of the specific health facilities, is it doctors as well who are the head of Mbabane, Mankayane, Nhlangano, Matsanjeni? Is it doctors who are sent to those positions to head the institutions of the health institutions in all the areas where there are health centers?
In the hospitals and in the health centers, and as well as in the regional administration. Now, you'll find what is called then the tripartite management. Now, the tripartite management means that there is the senior medical officer, there is the administrator, there is the chief matron. Now, those form what is called then the tripartite management. Now, those are what is then used as the leadership or the management of that facility. But what we have seen disturbing with that is that then you find that many a times decisions are not taken because those three cannot meet, those three cannot reach consensus, those three cannot work together. See, that is what we found to be a difficulty in terms of then the delivery of services. That is why we would appreciate that we adopt a system which would say somebody must be in charge. Yes.
So you as Swadnu, you are proposing a system where there needs to be a general manager, maybe one person who has management control of all the skills in the hospitals, who can be the head of the hospital or health.
Yes. At the end of the day, somebody must account. Somebody must account for decisions taken. Somebody must account for what has happened in the facility. Somebody must account for the general operations of the facility. So you can't have three people, and at the end of the day, no one is going to be held accountable for whatever that has happened, whatever that is taken as a decision of the facility.
So yeah, I mean, when we talk about some of the challenges, President, the issue of funding always comes into play, and some of the ideas that we've heard from activists in the health sector is the idea of the national health insurance. How do you perceive it as well, and how do you think it would operate? And how do you think it will operate differently to the current funding model of the health system?
Well, our view as an organization is that is the way to go. And our argument is that definitely it is clear now to everyone that the funding of the healthcare system through the government machinery is no longer working. If you go back to the finance budget for government 2017-2018, you will appreciate that government allocated 1.8 billion to the Ministry of Health. And when you zero into that, you will appreciate that it is far, far below what the Abuja Declaration requires.
Okay.
Through the Abuja Declaration, countries agreed that 15% of the total budget must be allocated to finance health systems. But if you look at that, you'll appreciate that in Swaziland we are standing at 9.1%. Now, that then says the Ministry of Health has no adequate funding that will enable it to operate or run the healthcare system and be able to deliver quality health services to the population.
Yeah.
Now, when we were engaging with government in terms of, converting what we call the civil service scheme now to become a medical aid scheme, we opposed that idea as an organization. Now, basically, to say a medical aid scheme is driven by capital, and the medical aid scheme is mainly to maximize profit for capital, and it is not a vehicle that is going to assist the poor person to access healthcare services. Now, we are saying let's engage on the debate around introducing or establishing a health insurance. Now, for us, what it means is that it will go a long way to mobilize necessary resources to build infrastructure, to introduce high technology within the health service, to also address the issues of human resource shortages, to also address the issues of drugs and medical supplies that are always now inadequate in the facility. Now, it would go a long way to address the financing the programs that are necessary for the healthcare system to operate. Now, it is not what to say what we are raising, it's something that is not known. We've seen other countries in Europe, like Britain is using the same model. USA through the Obama case using the same model. South Africa is also seeking to introduce the very same model. So we are saying it's high time as a country we also look at how do we establish a health insurance that will ensure that every citizen of this country is able to access healthcare services at a very low cost, at the same time accessing full supermarket approach, I would say, in terms of accessing healthcare services. Yes.
Now, the National Health Insurance, how would it work for me as a citizen and taxpayer? What do I need to do? Do I have to join somewhere, or automatically by virtue of being a citizen or a resident, through paying my regular taxes, pay as you earn, and the other taxes I pay, like the VAT, I will then be contributing to the National Health Insurance? How does it work in terms of the payment of the contribution from the public?
I think for us now is to say, let's engage on the debate. To say that debate will entail what will be the payment model, in terms of the health insurance. Let me make an example. Now, in the country, we have a lot of pension funds.
Yeah.
We can utilize some of the pension funds to establish the health insurance. Again, we can have individuals contributing to the health insurance fund.
Yeah.
And again, that fund can as well be able to generate resources itself
On its own, yeah.
on its own. So to limit the burden on then the taxpayer.
Yeah.
So I think
there are different ways.
Different ways of how to implement it. But I think what we're saying let's engage on the debate. And see what is feasible for us.
Now, in terms of the National Health Insurance and generally the issue of remuneration of healthcare workers, it's been an issue of big debate in the country. We've seen, for instance, you talked about the nurses who left, the health workers who left for UK and Canada and Australia. And part of those issues, of course, were the challenges in terms of the demands that you had at that time for better remuneration as healthcare workers. We've seen recently doctors, I think their allowances have been cut, if I'm not mistaken, from what they were getting. They were getting very healthy allowances. Do you regard that kind of a payment model to be feasible as Swatnu? Or a payment model like the one I meant to believe is given to nurses, a monthly flat allowance, or an allowance per shift as the doctors were given, which amounted to exorbitant amounts, where myself as a taxpayer, maybe I would feel that maybe we are paying a lot to health workers than we are supposed to pay as a country. Is there a limit? Is there a limit to the remuneration of health workers given the nature of their work?
Our view, Comrade, will say it can depend. It can depend how then the debate around the issue of health insurance goes. But our view is that the health insurance will not substitute the employer. Our view at the moment says if the employer is government will remain the employer.
Okay.
Now, if the employer is private sector will remain the employer. Now, and so such that then the employer must continue to respond to its obligations as an employer.
Yeah.
Now, but what we are saying is that the National Health Insurance will create a situation where our healthcare system will be boosted financially, such that we are able to develop skill in the country. we are able to develop specialities in the country, so that we no longer refer people outside the country for specialized care.
Yeah.
Now we are able to bring automated machines within the country.
Yeah.
We are able to procure adequate drugs and medical supplies.
Yeah.
Now, to say we have enough resources to run our healthcare system and our people can then receive quality healthcare services.
Yeah.
That's our view.
Maybe the last one on the national health insurance. Do you envisage a situation where a working class or poor person who can't afford, who under normal circumstances doesn't have medical aid and can't afford the charges of the private sector healthcare system, will that be possible through the national health insurance? If say I'm sick and I'm in Mankayane and they see that maybe it is one of the private hospitals that can help me, they have the facility. Will that the national health insurance enable me to be processed to the private hospital without having to pay from my pocket?
Yes, the good thing about the health insurance that we must appreciate is that the health insurance allow you to access care wherever it is. Now, if that kind of care is available in the private sector, the health insurance is able to pay for you for that care, for you to access that care.
Okay.
Now, the good thing again is that the national health insurance will create a situation where it is able to regulate the prices and the fees that are being charged in the private sector.
Oh.
The exorbitant fees that are being charged in the private sector. It is able to regulate that people are charged for what has been done.
Yeah.
Because you will appreciate that now you find people going to facilities for certain procedures, but you find that other different procedures are conducted to them,
Charged.
so that they are able to accumulate more resources out of that.
Yeah.
Now, so that is what then the National Health Insurance will seek to normalize. Again, the National Health Insurance will kind of close the inequality gap.
Yeah.
Between those who have got money and those who have got little money to live on.
Yeah.
Now, in the sense that even if you don't have money,
Yeah.
but you'll be able to undertake whatever procedure, no matter how expensive it is.
Yeah.
So it will not be determined by how much money you have. So it will be determined by the fact that you are part of then the insurance fund, and therefore the insurance fund must insure you for any procedure that you need to undertake. Yes.
Well, I think we understand. And I think we do need the expansion of the debate so that a lot of our citizens are able to understand where SWATNO and where a lot of activists in the health sector are coming from with the national health insurance. Because for some of us, we just think it's another medical aid, which we, of course, might be opposed to, because medical aids are also part of the insurance system that is creating a lot of uneven wealth in the world. Now, President, maybe on the issue of the health system in the country, one of the issues that we have witnessed or that we have experienced for decades now is some of the challenges that affect communities, that affect women in particular. The issue of people who have to guard, or you call them lodgers, the people who sleep in hospitals, the relatives of people who are sick, and many other challenges that that are up for debate within the health sector. What concerns me as an observer is that hospitals like Good Shepherd, for instance, which are not private, are able to do without some of those systems. What is the challenge in this perspective of nurses that necessitates that if someone is to be admitted in hospital, the nurses or the doctors, whoever is admitting them, will ask who is going to remain with this patient, instead of saying, Siyabonga, the patient has been admitted, you observe the visiting hours when you come in to visit them. What is the take of health workers, particularly nurses, when it comes to such issues in the hospitals that cause conflict now between the nurses and the people who access them? Because when I bring a relative and I can't bring a lodger, I'm sure there have been tensions between the people who are in the hospital and those particular people who can't lodge or who can't bring a lodger to a hospital. What has been the challenges that have brought, and what are the legal implications? And I don't know whether the laws have normalized it or it's still done outside the laws. We just turn a blind eye as government and health practitioners.
Our position as an organization that we have communicated even in the previous government, in the previous administration, now is that government must do away with then the issue of lodgers in the hospitals. Now, for this reason, now when you have got lodgers in the facility, you are actually increasing the chances of those people acquiring infection within the facility. Now, you must appreciate that facilities are areas where there is a lot of infections. Now, if you have too many people, it becomes very difficult to follow infection control measures. Now, that is one thing. But the second aspect that we have raised, we have said government must increase the number of nurses and the number of other healthcare workers. Now, for instance, your support staff, because it becomes very critical for them to take care of then the patients in terms of assisting the patients in feeding, assisting the patients in taking their bed bath, assisting the patient in terms of cleaning the wards. So it becomes very important to have enough of your support staff. Now, because then you would appreciate then that the lodgers are doing the work that should be done by the support staff. Okay. So that is what we are raising with government. Now, to say, let's employ more support staff, let's employ more nurses, and then do away with lodgers. Yes.
Okay. So, and how far has that gone in terms of, is it an issue of negotiation or is it an issue of policy that government will say, we hear you, but we are working on it?
No, it just becomes an issue of policy. Which government can today issue a policy statement and say no more lodgers in facilities, and it will be done. It doesn't require negotiations. It doesn't require a lot of engagement. It's just an issue of issuing a statement, and people will abide by the statement.
But you mentioning the issue of lodgers again, President, you go to hospitals like, I don't know whether it still happens now, Nazarene, where the lodgers are kicked out at night. You find some sleeping in the main admin hallway and things like that. You get a sense that they are not welcome in the wards. I don't know whether it's an issue of saying they are not welcome in the wards, or it's an issue of I don't know how they, because it's like they are needed, but at certain times they need to be kicked out of the facility. Hospitals are playing both sides. On the one hand, they would want the patient to have a lodger. On the other, they don't want the lodger to sleep in the ward and you wonder where the lodgers would sleep, knowing that people will come from places far away to guard their relative in hospital.
That is the unfortunate situation, my leader, because we must appreciate that these are our mothers, these are our relatives, these are our sisters and brothers, and for them to be treated in that manner, in my view, is not correct.
Yeah.
But again, it then demonstrates lack of policy within that facility or within government as a whole. Now, because it then says there was no arrangement even in the introduction of lodgers to say where are lodgers going to sleep, where are lodgers going to get water to clean themselves. You see, so it becomes a situation where no one can be accountable for, because you can't even say if a lodger is experiencing, I would say, ill treatment in the facility. Who has to account?
Yeah.
You see, is it the management that has to account? Because the management will say, I have not admitted this person.
Yeah.
I have admitted the patient.
Yeah.
And I'm only accountable to the patient. So I think it's an issue that needs to be addressed. To say the issue of lodgers, in our view, lodgers must not be allowed to be in facilities. But I think nurses must be able to do their work, and support staff must be given the opportunity to do their work, and patients must be satisfied and be comfortable with the care that they receive from their care workers.
Yeah. Now, I want us, President, to move to the trade union part of the SWATNU struggling. You have been in the leadership of the nurses union for quite some time. Where did it start for you, this trade union journey?
Well, I joined the organization when I was still a student at the then Institute of Health Sciences, which is now the Faculty of Health Sciences. I was the vice president of the SRC until I met Comrade, former president of the organization, Comrade Africa Mokongo, who introduced me to the organization. I started then to attend the meetings of the organization when I was still a student.
So was Africa a student then? Was he pursuing his further studies? Because I remember in the late 90s, I think he was a student again at Bavana Kemba. Did he go back twice?
Yes. He went back to the Faculty of Health Sciences to undertake a course, a degree course on, I would say, nursing management. Yes. But we had already met with him, and it's the one who, gave me a historical background of the organization, because by then the organization was at its formative stage, I would say, and people like Africa were the founders of then the organization. So that is where I was motivated to be a member of the organization. And when I came, and when I joined the working environment,
a good shepherd,
I then became the chairperson of then the Lubombo region. And then from there, I was then elected as the deputy president of the organization around 2002.
And
then,
who was the president and secretary general when you became vice president?
my president by then was Comrade Bheki.
Okay.
And the secretary general was Mama Julia Ziad.
Ah, okay.
Yes,
Okay.
yes.
Okay.
Yeah.
So, and then Africa at that time, was it still around? Was it still alive? May he so rest in peace when you became vice president.
Yes, Africa was still alive by then. He was then the president of the federation. At that time it was
SFTU. I see. Yes. So when he was elected president of SFTU, that's when he relinquished his position as
yes, he relinquished his position as the president of the Swaziland Nursing Association by that time, and then became the president of SFTU.
Yeah.
But he was still critical to groom some of us within the leadership of the nurses organization, because by then the organization was still, maturing.
Now, the organization and trade unions in general, I don't know what your view will be. In this country, they are growing younger and younger in terms of leadership faces. When me and you joined in the early 2000s, the leadership was mainly people 55. What has happened? Is it reflective of the membership, or maybe the older generation is getting less and less interested in leading?
Yes, I think my view will say, again, we must appreciate that the workforce in Swaziland, it's comprised of the young generation. As you will see in Europe, you will find that the workforce is more of the older generation. So obviously, you will then expect that even the leadership of the trade union movement will reflect that. Again, what we are seeing is that as people get older, and also as people join the management position, they relinquish their activism within the trade union movement. And then you'll then remain with the young generation that is leading the trade union movement. And I think again, for me, that's a positive aspect, because it then says you'll have the young generation taking up leadership in the organization at a very opportune time.
And they build the necessary experience as they
build the necessary experience as they grow with the trade union movement. So I think for us, it's a positive. And
now you are now the one of two vice presidents of the Trade Union Congress of Swaziland. How did that happen? When were you elected, and how has that experience been for you?
For me, it's quite an experience because it's my first time to become part of the leadership of the federation, of which I take it as an experience. I'm opening myself to more to learn and more to give my effort to build unity and cohesion within the trade union movement in the country, because my view is that that is what is very critical and also very at the moment necessary within the trade union movement. You would appreciate that if you look at the attitude of employers in the country, it is becoming more and more harmful when it comes to issues of workers and issues of trade union operations in the country. So I think I'm taking a challenge, and I'm working to see how that the end of the day pans out.
Now, controversial question, President. I'm sure Tukosa will go to Congress soon. What are workers and what is where is the wind blowing for you? Are you going to retain your position? Do you want to go back? What are workers saying about you going forward?
Well, the Federation is going for its Congress this year, and we are hoping that it's going to go smooth. And we are looking forward for the affiliates of the Federation to elect new leadership of the Federation. I really cannot say that I'm going to retain my position, but if then the affiliate feels like I need to remain within the Federation leadership, I will accept that proposal.
Yeah. No, thank you very much, President. I think we've had a very engaging first experience of workers, and we will have more workers and possibly you for the second time quite soon. You've been a great guest. Thank you very much for coming.
Thank you very much, my leader. Thank you very much.
Yeah, thanks.